Good morning. Thank you very much for inviting me to speak on this panel, and I look forward to our conversations. My name is Lynn Dengel, and I'm with the University of Virginia, and I'm going to be speaking about the potential of focused ultrasound as an immunotherapy tool for the treatment of melanoma. Melanoma serves as an important immuno-oncology model, as you can see here in the picture of the melanoma with many tumor-infiltrating lymphocytes. And we know that patients who have higher levels of tumor-infiltrating lymphocytes within their primary melanoma have a better overall prognosis. This prognostic impact of immune reaction in melanoma has fueled immunotherapy research for these patients. And there's been recent successes in immunotherapy with T-cell checkpoint blockade, adaptive T-cell transfer, and vaccination immune therapy. But overall, only 10 to 50% of our patients respond, and the responses are not always durable. Tumors continue to escape the immune system and limit the success of these immunotherapies. They do this by preventing penetration of the immune cells into the tumor microenvironment, by blocking necessary immune activation signals in the tumor microenvironment, and inhibiting differentiation and function of immune cells. There's a clinical need for improving on current immunotherapy models for our patients. Focused ultrasound has the potential to assist in this need to improve current immunotherapy or to bolster the patient's innate immune response. At sites of focused ultrasound, we can see increased tumor antigen release and antigen capture, leading to greater presentation of the lymph nodes, increasing circulating tumor-specific T cells and T cell recruitment at the tumor site. In addition, focused ultrasound leads to increased permeability at the tumor with increased cytokine expression and adhesion models. There have been several studies published on the clinical utility of focused ultrasound. This study by Liu et al. In breast cancer patients demonstrates the activation of tumor-infiltrating lymphocytes after treatment with high-intensity focused ultrasound. As you can see by these H&E stains, the increases in tumor-infiltrating lymphocytes were not at the coagulative necrosis or ablative zone, but in the peripheral zone surrounding this high heat area. There's only one other current study listed on trial.gov in melanoma, and this actually uses focused ultrasound in a different capability where the study aims to open the blood-brain barrier and improve delivery of drugs to the tumor site. Our study looks at the original purpose I spoke about in terms of focused ultrasound increasing the immune response in tumors. We developed a study called AMO03 that uses focused ultrasound to bolster the immune response in patients with advanced solid tumors. Focused ultrasound is used either alone or in combination with systemic therapy to provide additional stimuli, hopefully to overcome tolerance, induce greater dendritic cell and T cell activation. And our hypothesis is that by using a spot or a partial focused ultrasound ablation model, we will optimize the immune reaction created by focused ultrasound to improve this immunotherapy reaction. Study population includes patients with advanced solid tumors. They must have measurable disease and regional or distant metastases, and at least one of the metastases has to be accessible for focused ultrasound and biopsy. We anticipate that most of these metastases will be dermal, subcutaneous, or nodal. Patients fall into the following clinical presentations. Either they've had progressive disease after other therapies, or they are not eligible for other therapies, or patients who have been on systemic PD-1 blockade for 12 weeks with stable disease, who clinically, under standard of care, would be kept on this therapy, but would be expected to have a fairly low response rate. The treatment protocol has two separate regimens, and within each regimen, there's two cohorts. In the first regimen, patients are treated with focused ultrasound alone or focused ultrasound plus systemic PD-1 blockade. Patients who tolerate this first regimen and have lesions amenable to a secondary treatment can go on to regimen 2 in the same arms, but adding topical imiquimod to the treatment, to the tumor where the focused ultrasound is targeted. The lesions are required to be approximately 1 centimeter or greater of tumor volume, and the targeted tumor volume must be at least 5 millimeters, but no more than 2.7 centimeters from the surface, with an anterior-posterior dimension of at least 9 millimeters. The tumor may involve the dermis as long as we are able to target the focused ultrasound below the dermis to meet the above criteria. The protocol is designed truly to optimize the immunostimulatory effect as opposed to the ablation effect of focused ultrasound. So we deliver a single course of treatment over a small 5 to 10 millimeter diameter area. And the treatment is only applied to 33% of the estimated tumor volume. Multiple assessments are obtained throughout the study to look at both the response in blood and also there are biopsies before, immediately after, and delayed after focused ultrasound. The primary endpoints look at safety, but also the immunological effect. And the primary immunological effect we're looking at is the reaction of the change in the CD8 T cell infiltration after focused ultrasound. Secondary immunological effects is to estimate the change in T cell infiltration in untreated or distant metastases. We have several exploratory endpoints to further delineate the response to focused ultrasound in these cohorts. We will also be looking at clinical response in the primary and secondary regimen. I wanted to show a few pictures of a treatment session so I could illustrate our protocol a little bit more clearly. Here you can see the outline of the tumor that we're targeting with this treatment session. As I stated, our goal is to really do a spot focused ultrasound model. So when we select the areas for a target, we not only just select a portion of the tumor overall, but within that portion that we're going to target, we also select and skip certain focus zones so that overall we create these secondary zones in addition to the primary ablation zones that you can see here in green. After treatment, we look for this echogenic foci at the site of ablation to illustrate that we had appropriate energy and a good response to treatment. Our post-biopsy treatments are targeted at the peripheral zone rather than at the area of tumor ablation. So you can see here, in this tumor, this is the primary area where we ablated with focused ultrasound, and this is the site where we aim for a biopsy of the tumor. So far, 3 patients have been enrolled and treated in this trial with metastatic thyroid and colon cancer. Recent enrollment has unfortunately been challenging. We attribute part of this to the COVID pandemic and decreased enthusiasm for patients traveling to trial sites. We are working, though, to try to increase our trial enrollment and considering trial amendments, including looking at the regimen 2, which is the regimen that allows patients to go on to a secondary treatment using imicamod. And we're considering switching this to poly-ICLC, which is an injectable, which would increase which would broaden the inclusion criteria so patients wouldn't need superficial tumors for treatment, and we could treat subcutaneous metastasis in the secondary regimen. I'd like to thank the team that I work with at the University of Virginia and, of course, the Focus Ultrasound Foundation for their support for this trial and also in organizing this panel. I look forward to talking with you about questions that are come up in our studies and challenges that we're all facing to investigate this important tool. Thank you.